Good afternoon, everybody. Thank you for joining us today for our webinar series, Data to Drive Decisions. We are going to be talking about understanding the importance of continuous healthcare insurance enrollment for access to care today. We're thrilled to have some wonderful presenters. Just a little housekeeping. All lines are muted. Please ask questions in the chat box. We're going to hold all questions until the end. This webinar is being recorded, and all the slides and a link to the recording are going to be posted on our event resources page at civic.org. My name is Carrie Frank, and I am the Vice President of Communication and Marketing. And I'm thrilled to have two presenters with us today. We have Sarah Gordon, and she's Assistant Professor at Boston University School of Public Health. And she's joined by colleague Beth Martin, who is Senior Data Analyst at Colorado Department of Healthcare Policy and Finance, which is Colorado's Medicaid department. Just a quick agenda. We'll go over very quickly as an overview of CIVIC and the APCD. We will discuss the impact of the ACA on continuity of coverage among the marketplace and Medicaid. And we will review findings of Medicaid expansion on postpartum care and utilization, and then look over Medicaid churn patterns before COVID and during the public health emergency, and talk about some new resources that are have been developed to monitor Medicaid churn. So to just give you guys some background on CIVIC, in case you're new to our organization, our mission is to empower individuals, communities, and organizations through collaborative support services and healthcare information. And everything that we do is to advance the triple aim of better health, better care, and lower cost. We're a nonprofit organization, and we're independent and objective. And we serve a variety of stakeholders. Two are on the phone with us today, our presenters. So we help researchers with information, and we support state agencies, government, and then everybody that surrounds and touches healthcare, clinicians, hospitals, health plans, nonprofits. Everything we do is with a consumer in the center, and all of our stakeholders are ultimately supporting making Coloradans healthier. So we're going to be talking a little bit about APCD data. Not everything that you're going to hear today is based on the Colorado All-Payer Claims Database, but some of it is, and just a reminder that it does have all payers, commercial, Medicaid, Medicare, and Medicare Advantage, representing the vast majority of insured Coloradans in the state. We have over 700 million claims, representing 44 commercial payers, Medicare and Medicaid, and then coverage for roughly, in any given year, it's over 4.5 million people. And we use that information on a public basis, and we've done a lot of webinars that go over our public data. And what we're going to be talking about today is non-public data that we also license to help researchers, state agencies, and others who are looking for opportunities to inform the AAA. So I actually am going to stop now and stop sharing and turn it over to Sarah Gordon, who's going to take it away with her segment of the presentation. So thanks, Sarah. Welcome.
Thank you so much, Carrie, for that introduction. So everyone see my slides okay? Awesome. Okay, well, thank you so much. I'm so excited to be here. My name is Sarah Gordon. I'm an assistant professor in the Department of Health Law, Policy, and Management at the Boston University School of Public Health. And this really feels like a culmination. I've been working with the Colorado APCD since I was a doctoral student at Brown University. I think I first started working with it back in 2015 or 2016. So really when the data were in a nascent stage. And so I'm really interested in continuity of insurance coverage, which is the topic of this webinar. And because of that, I've repeatedly returned to using the APCD because it's one of the best ways to really understand how people move through the healthcare system. So I'm going to be giving a whirlwind tour of a lot of different research I've done over the years in different markets looking at continuity of coverage using the APCD. So a couple of disclaimers. So currently I'm working at ASPE in the Department of Health and Human Services. So I just have to say that everything I'm presenting in this talk does not reflect the views of HHS. And over the years, I've had different funders for this work, including ARC, my institution BU, and the Commonwealth Fund. So before I jump into the actual research, I thought I would start with an introduction of this concept of insurance churn and what we mean when we're talking about insurance churn. So this term churn refers to moving in, out, or between different types of health insurance coverage. And this can happen to people over the course of their lives for a lot of different reasons. It can be because of a fluctuation in income. Of course, with employment, gaining a new job or losing a job, you may have to change your employer-sponsored coverage. Typically you do. Family status, marriage, divorce, birth of a child. And also eligibility. So in terms of eligibility, for example, marketplace coverage or marketplace subsidies or a Medicaid program. And then another source of churn relates to administrative issues. So perhaps this is fairly common in Medicaid. Perhaps people can't actually get a hold of an enrollee due to an address change, or perhaps there's language barriers to filling out application paperwork. And so there can also be just administrative driven churn where someone might be eligible but cycle in and out of coverage. So in Medicaid in particular, there's research showing that the typical Medicaid enrollee is covered for less than 10 months, and that 1 in 4 Medicaid enrollees will change coverage within a given year. So there's been a lot of research on the effects of churning or the effects of discontinuous health insurance coverage. So we know that people who experience disruptions in their coverage are more likely to delay care, to receive less preventive care, to refill prescriptions less often, and to have more ED visits. And these consequences of churn can occur even if transitions are seamless. So even if you transition from one type of insurance to another without any lapse in coverage, differences in provider networks, benefits, cost sharing can still disrupt continuity of care. Another important consequence of churning, particularly in Medicaid, is that it's been shown to increase Medicaid administrative costs. It also results in less predictable expenditures for Medicaid programs as enrollees come in and out. So some research has estimated that a single churning event, so losing coverage, coming back in, can cost Medicaid programs between $400 and $600. Churning also creates issues for providers who are trying to deliver continuous care. If you're trying to provide care for a chronic condition, for example, and you have a patient who's cycling in and out of health insurance, it's also hard to assess quality metrics with a changing population in a health plan. So the agenda for today, Carrie mentioned this, I'll just quickly go over it again. So I'm going to be talking about a couple different studies, both starting with looking at continuity of coverage in the marketplace. Then I'm going to move to a body of work I did looking at the effect of Colorado's 2014 Medicaid expansion, specifically looking at continuity of coverage among low-income adults and then also among pregnant individuals. And then lastly, I'm going to share some very preliminary work that's looking at the potential effects of postpartum Medicaid extensions. So study 1 looks at risk factors for mid-year disenrollment from Colorado's Affordable Care Act, so individual health insurance marketplace. So for this study, I used the Colorado APCD from 2014 to 2016. I looked at non-elderly adults and excluded plans that only provided dental coverage or were grandfathered pre-ACA plans. And so here I was really interested in understanding rates of mid-year dropout. So this is not people who are dropping out of the marketplace when it's time to choose a new plan. This is people who are really partway through their plan year, just dropping out of coverage. And I was also interested in sort of who that is, what is associated with that mid-year dropout and where do people go. So the first finding I want to highlight here is that I found that among all marketplace enrollees, 24% approximately disenrolled mid-year, which is pretty high, but it's also consistent with what's been seen in other state marketplaces. And you can see if you look across these categories in this table, I separated it by metallic tier and also by whether enrollees received cost sharing reductions. And you can see that those, I wonder if you can see my mouse here, I'll try and circle it. Those who are in silver plans who receive cost sharing reductions are actually the least likely to disenroll. And those who are in typically less generous bronze plans are the most likely to disenroll mid-year. And in terms of how long people are actually enrolled over the year, on average, it's about 75% of the year. And again, we see the same patterns where here, the silver enrollees who receive CSRs are enrolled for a longer portion of the year, and those who are in bronze plans are enrolled for less time over the course of a year. And then we can see also somewhat predictable patterns in terms of where people transition to when they drop out of the marketplace. So those who receive cost sharing reductions by definition are lower income, so they're more likely to transition to Medicaid. Those who choose to purchase more expensive gold plans are more likely to transition to commercial coverage. So the key takeaways from this study, and for all of these, I just want to highlight, I included the source, the reference for all of these papers, which are all published. So if anyone's interested in anything further, they can definitely go and look it up. But the key findings I want to highlight are that, almost 1 in 4 Colorado marketplace enrollees changed or lost their insurance mid-year, and that more generous plans with higher actuarial values, enrollees who were in those plans were less likely to disenroll. I also found that young adults were more likely to disenroll early, which is not great for insurance risk pools because young adults tend to be a healthier population. And interestingly, I also looked at utilization trajectories before people dropped out. And interestingly, those who dropped out had higher utilization of ED and inpatient hospitalization services compared to those who did not disenroll mid-year. So I don't know, this is just speculation, but one potential explanation would be that maybe if you're in a plan that has a lot of exposure to out-of-pocket costs and you have an expensive event, such as an ED visit, you sort of realize how much you might have to pay out of pocket for a plan, you might decide it's not worth it and drop the coverage. So I'm going to move on now to this next question, specifically around Medicaid expansion. So here in this study, I was looking at the effect of Medicaid expansion on continuous enrollment. And for this study and the next one I'm going to present, I used the same setup and the same data. So here, I wanted to compare a state that had expanded Medicaid, so Colorado expanded in 2014, to a state that didn't. And so what I did was I appended the Colorado and Utah all-payer claims databases, neighboring states that had taken different approaches to the Medicaid expansion decision at the time. We know Utah has since expanded, but so in these data years from 2013 to 2015, it was this nice side-by-side comparison. And I was also very, very fortunate because at this time, both states used the same vendor for their APCD. So it was much, much easier to combine these data sets and feel that the fields were reliable and consistent across the two states because they were pretty much the exact same extracts. So I used what's called a difference in difference analysis, where you compare across states pre and post a policy change. And I specifically looked among those who were enrolled prior to Medicaid expansion. So this is sort of the main finding from this analysis. And so what this is showing, the blue bars are rates of disenrollment from Medicaid, and the orange part of the bar is a gap in coverage. And the left panels are all Colorado, and then the right side of the figure is Utah. So a few things to take away. At baseline, Colorado had lower disenrollment from Medicaid than Utah, which makes sense. They had more generous income eligibility limits for Medicaid at baseline. But then in 2014, when the expansion goes into effect, we see this big drop off in terms of both disenrollment and gaps in coverage in Medicaid, and we do not see that in Utah. So it's pretty clear that expansion was associated with improvements in continuity of coverage. So I'll save you all the fancy modeling, but after expansion, we found that Medicaid enrollees in Colorado gained about 2 additional months of coverage compared to their counterparts in Utah, which didn't expand, and that they also experienced an over 50% decrease in the probability of having a disruption in their coverage in a given year, which is a big decline. So when I was doing this analysis, I looked at these effects and I noticed that they were driven largely by one eligibility categorical group in Medicaid, which was pregnant women. So the next step for me really was to try and understand what was going on there. And so in this study, I used the same setup, but I looked specifically at the effect of Medicaid expansion on postpartum Medicaid enrollment and utilization of outpatient care. So just in case anyone's not familiar with the Medicaid eligibility policies for pregnancy, so in Colorado, pregnant people with incomes below 265% of the federal poverty level are eligible for pregnancy-related Medicaid from conception through 60 days. At that 60-day time point, the eligibility rules change because pregnancy-related Medicaid eligibility ends, and if someone is going to stay enrolled in Medicaid, they need to qualify through a different eligibility pathway. So prior to Medicaid expansion, that was just the parental limit, which was 105% of the federal poverty level. After expansion, it was raised to 138, right? Because that was the limit for all low-income adults. So I look at both of these changes, and even after expansion, those between 138 and 265% FPL would lose Medicaid eligibility and would then need to find commercial insurance either through the marketplace or through an employer, or risk becoming uninsured. So the first question I wanted to answer was, does Medicaid expansion mitigate postpartum coverage loss? The idea here being that Medicaid expansion as a policy, both in the prior study and in this study, increases the income range within which incomes can fluctuate before people actually hit that limit and then are no longer eligible for the program. So that was my hypothesis. And this is a paper that was published in Health Affairs last year. Again, the citation is provided at the bottom of this slide. But basically the answer is that yes, Medicaid expansion did improve continuity of coverage. So this figure shows trends in the mean number of months of postpartum Medicaid enrollment in Colorado and Utah. So the blue line is Colorado and the, I guess, lighter blue line is Utah. And so here we found that expansion in Colorado was associated with about 0.9 months of postpartum coverage over a 6-month period. And this number was 1.4 months among this high-risk group that experienced severe maternal morbidity. So that's a group we really care about providing continuous coverage for and making sure that they have access to care during the vulnerable postpartum period. Then we looked at outpatient visits. So this is sort of an access to care measure during the same period, this 6-month postpartum period. And again, you can see this uptick in Colorado on outpatient visits. And we found that expansion was associated with 0.5 additional outpatient visits over this 6-month period. And this is 1.25 among this high-risk group with severe maternal morbidity. So key takeaways here, we found that Medicaid expansion was associated with increased stability of coverage during the 6 months postpartum and increased use of outpatient care. We found that these utilization gains were really concentrated and larger among this group. We're really worried about having continuous coverage. This group that had severe maternal morbidity, which is basically an adverse risky event that happens as part of a delivery complication. And finally, because we had an all-payer claims database, I wanted to look at what happened to people if they left Medicaid postpartum and where they went, and whether their utilization trajectories of outpatient care was the same as it would have been if they had stayed in Medicaid. So to get at this, I basically tracked the people who transitioned to commercial coverage and found that they did not use commercially financed outpatient care at the same rates that they used Medicaid financed outpatient care, which suggests that there is some cost to making that transition to commercial coverage. Commercially financed outpatient care during this period might not be an exact substitute for Medicaid if people are being pushed to that market. Okay, so this is the last study I'll present findings from, and this one is very preliminary. I am just submitting this for publication now, but I wanted to talk about it because it leverages collaboration and data linkages, which I'm really excited about. So here I am really interested. If we go back to this figure, I'll just orient everyone to the policy that I'm looking at. So now we're fully in the post-Medicaid expansion period, the post-2014 period. And I'm interested in what happens to these folks. So what happens if you are enrolled in Medicaid during pregnancy, but then you lose eligibility postpartum? So this is really relevant because in the American Rescue Plan, which was passed in March, this legislation gave states the option to receive FMAP matching funds if they extend pregnancy-related Medicaid eligibility out from 60 days up to a year. So this is something there's a lot of state interest in. Colorado has enacted legislation to seek federal approval for a waiver for this extension. So there's a lot of interest in this and not a ton of data. There's not a really good way to answer this question of sort of comparing commercial versus Medicaid insurance in the postpartum year. So enter the APCD, which is really great for answering these types of questions. So I was interested in trying to understand what the effect of Colorado's postpartum extension would be on continuity of coverage in the postpartum year. So I used 3 data sources. So I started with the Colorado APCD, but then with the help of CDPHE, linked the APCD to birth records. So that this is really important, because one of the limitations of the APCD is that while it has really great information on utilization, it often lacks certain demographic characteristics, which we'd really want to know, things around race and ethnicity, educational attainment, income, marital status, et cetera. So things that we know are related to healthcare use, but aren't always included in claims. So a lot of that is in the birth record. So it really fills in this gap and is a really powerful linkage. And then we also linked this birth record APCD data set with individual level income data provided by HCPF. And so we really have like individual level income and the birth record and the APCD. So really, really rich data. So I won't get into the nitty gritty econometric details of this, but we use something called a regression discontinuity design. And basically this approach takes advantage of this 138% FPL cutoff as basically a form of random assignment, because those with incomes below that cutoff are eligible for Medicaid and those with incomes above the cutoff are not. So it creates this sort of natural experiment way to compare what happens and to evaluate the effect of Medicaid eligibility postpartum. So this figure, so we looked at a few different outcomes, one of them being the mean duration of Medicaid enrollment in the postpartum year. And so this figure shows the duration of Medicaid enrollment against income, and the vertical dashed line here is this 138% FPL cutoff. So we're interested in comparing sort of the left panel to the left of the dashed line to the right of the dashed line. And you can see that those with incomes below 138 who are eligible to stay on Medicaid typically are enrolled for more months out of the year, closer to 12. And those with incomes above 138 who are going to lose Medicaid eligibility due to their income are enrolled typically for fewer months during the year. Similarly, we looked at the probability of having a disruption in coverage, and again, see a very similar pattern where those with incomes below 138 who are eligible to stay in Medicaid are less likely to have a disruption in their coverage, and those who lose Medicaid eligibility are more likely to have that disruption. So here are all the numbers from our modeling on this. One thing I just want to highlight is this finding around coverage gaps. So I think this is really important because it gets to this question of whether these transitions in coverage are seamless. But we find that those who lose Medicaid eligibility are much more likely to have a gap in coverage as well, which indicates that even though people might have an alternative coverage source, that transition might not be seamless. They may have a month or two without coverage. So key findings here, loss of postpartum Medicaid eligibility led to worse continuity of coverage in the postpartum year, and that the availability of alternative insurance does not necessarily mean that that is going to be continuous coverage. So we find that those with incomes above 138 who lose Medicaid eligibility are much more likely to be in commercial or marketplace coverage, makes perfect sense. But we also find that they're more likely to have a gap in coverage, which would indicate that the transitions are not necessarily continuous and seamless. And broadly speaking, I think there's some national implications here. So, you know, this suggests that states that adopt this option, which many states are sort of have waivers pending, introducing legislation around this, will likely improve continuity of coverage for this group in the postpartum year. So, taking a step back, I have a few takeaways from, I think, approximately 5 years of working with the Colorado APCD. The first is that this is a really vital resource for trying to understand how people move through the healthcare system. You know, I think Carrie was saying just before we started the webinar, you know, we talk a lot about continuity of care, but really continuity of insurance is a precursor to that, right? You have to have continuous enrollment in coverage in order to reap any of the benefits of continuous care. So I think, in the landscape of data, we have self-reported information about health insurance enrollment, but APCDs are the only resource that I know of that really allows you to look at the claims and look at the real administrative enrollment data to try and understand how people move through the healthcare system. And if we don't do that, we're really only seeing a very small fragment of the healthcare system or of someone's care. In my experience, particularly I'm trying to publish using all payer data, it's very important to be explicit about the strengths and limitations of the data. I think really convincing people of sort of their value, and then also highlighting the areas of improvement, because I think this also helps push sort of the policy agenda forward in terms of where we need to be with making sure that APCDs are as comprehensive as they can be. And then I'm just really excited about this sort of new frontier of linkages. As far as I know, Colorado is the only state that has done this kind of linkage with other statewide data, the birth record in particular. And this is something that there's a lot of excitement about, particularly in the maternal health world, thinking about data linkages, but I think this is highly relevant to a lot of areas. So I'm hoping that this is something we'll see more of and that other states could emulate. So I have to give a huge, huge thank you to everyone I've worked with in Colorado over the years. At CIVHC, both Eddie and Aaron, Beth, you're going to hear from in a moment, for providing the income data from HCPF, and Kirk at CIVHC, who had the painstaking task of linking the APCD with the birth record. So thank you so much to everyone. Could not have done any of this work without your help. I'm happy to take any questions, but I think for now, we'll turn it over to Beth, right?
Yes, thank you, Sarah, so much. That was excellent. It's so exciting to see all the different ways that you're looking into the data and just using different resources and really understanding what's going on. So fantastic. I know we do have a question, but we will save it for the end. And just a reminder, if you guys have questions now, feel free to put them in the chat if you don't want to forget your question, and we are going to take those at the end. So Beth, we will turn it over to you.
So I am going to be discussing just a little bit about moving forward with population trends with Medicaid's population before the COVID public health emergency and during. And I am sorry, I'm going to do this again because I'm not sure why my
Sometimes you have to click on it on your actual slide to make it advance.
Right. Okay, we're going to try one more time. Okay. All right, now we'll try again. Okay, so now can you see the screen?
Not yet.
Not yet. Oh gosh, I'm sorry. Okay. Okay, now are we good?
Yes.
Okay, hopefully that will be the most difficult part of the presentation. So before we were going into our public health emergency, right before, HCPF is Healthcare Policy and Financing. That's the state agency that runs Medicaid in Colorado. We did a churn analysis looking at continuous coverage or coverage at all, covering the entire period of calendar years 2018 and 2019. And we chose to look at this 24-month period because there aren't set times when people come onto and off of Medicaid. So you don't have a time period of a given calendar year or 12-month period where people are eligible. So we looked at this longer time. We looked at the people by their eligibility categories as they were most recently assigned during that time frame. So at the end of 2019, whether they were a low-income adult or a magi parent or that sort of thing. The churn categories were assigned based on that person's eligibility experience over the 24-month period. We parsed this population down into 4 buckets. We had the stayers. Those were people who were continuously eligible for all 24 months. The leavers, those were the people who were eligible at the beginning of the time frame, but lost eligibility sometime over the 24 months and did not return. The joiners are the flip side. Those are the people who joined after the beginning of 2018 and didn't leave. Then we have the cyclers who had experienced at least one gap in coverage during that time frame. So during our Medicaid churn period, we had about 43% of our population who were stayers consistently over that 24-month period. And then about 21% who were leavers, 16% that were joiners, and 20% over the whole time frame who were churners at some period in time. And as you look at the graph, you see a decrease in our population overall. And that was, of course, because we were having a very good economic run. And so at any given time frame in that 24-month period, somewhere between 7 to 10% of our population was a cycler for that month. And we have a nice gradual transition between our leavers and our joiners. Churn, of course, reflects program design, which is very reassuring that it works the way it's supposed to work. For our low-income population, which is our most economically sensitive population, we see the higher churn rates. We have, our higher transition rates between the populations. We have between 38% of our low-income adults and 44% of our kids who were stayers the entire time, and 20 to 25% who were leavers and such. When you look at the condition-limited populations, and those would be the people who were eligible because they're pregnant, it also includes our emergency services only population. You see a much higher group being our cyclers and who are leavers than you do in our other populations, which makes sense because as we were looking at Sarah's graphic of the gap between the full pregnancy-related FPL and down to where you would qualify afterwards, there's a lot of people who are not going to fall in. So you see far fewer stayers. Down here at the bottom, we're looking at the populations that still have to meet the income requirements and such, but they are not as economically sensitive. This includes our older adults, it includes our foster care children, and our adults with disabilities. So we see them, of course, the population percentages that are stayers is much, much higher than our other groups. So to touch a little bit on the pregnancy-related analysis, we looked into this population based on this churn study earlier this year as we were going forward with the legislation to extend coverage for women who are pregnant. And what we found was that, of course, the people with lower incomes were more likely to be eligible for a full year after delivery than those who were in that the cutoff area, the people with an FPL of 134% or above. And that really correlates to the 138% because of some modifications that you do in the eligibility system to adjust. But we see a really large discrepancy between these two groups where only 16% of that higher income group is going to remain eligible for the full year after delivery, as opposed to 71% of the persons who have the lower income. So this is showing our transitions. So where do the people go after they deliver? This chart shows 1 month after that pregnancy aid code span ends. So for our Magi pregnant population, we see about 2/3 of the people transitioning directly into the Magi parent caretaker aid code, as you would expect, with the other third being almost equally split between Magi adults and being not covered. And again, that not covered group is going to be far heavily weighted towards your higher income population. We also have a second pregnancy-related aid code, which is legal immigrant prenatal. And so you see a much larger percent of those going to not covered, and that's an artifact of how the program works. So who is most likely to stay? Your kids and your elderly people. You're going to see about half of each of those populations who were stayers over the full 24 months. And very consistent percentages, about 20% leaving, 11, 12% joining, and about 20% cycling. And that's about what you see down with our elderly population as well. Now, one thing to note is with our infants, since they're under 2 years old, by definition, none of them are going to be stayers. But most of them are joiners. You know, they're born, they show up, and they stay. You know, they don't leave. We see, just as Sarah saw in her analysis, that the highest proportion of people who are leaving or cycling are going to be our youngest adults. That's consistent across, you know, all coverage communities as far as I can tell. But we do have a very definite gap here with our younger adults. Looking at the race ethnicity data, we don't see a whole lot of difference between our populations. We do see more change with our other or unknown, which we can't break out because we don't know who they are. But there's not a huge discrepancy, particularly in the cycling population. It's consistent across each of our race and ethnicity groups. So let's talk just a little bit about the cyclers. And these are the people who come off and on over the course of the 24 months. So it's common knowledge that people cycle on and off Medicaid a lot. Everyone knows that. As I was doing this study, what really surprised me was not that 1 in 5 members were cyclers over that time frame, but that it is not accurate that individuals cycle on and off frequently. Since we're covering right now 1.5 million Coloradans, it's still going to be a lot of people coming on and off, but only 5% of that population in that 2-year study had more 2 gaps in coverage in Medicaid, and 0.2% had 3 or more gaps. If somebody experienced a Medicaid gap, if they were cycling, 95% of them only came off Medicaid 1 time. And that surprised me. I've been looking at the Medicaid data for almost 24 years now, and very few things shocked me, but that one did. When you look at the cycler gap lengths, about 3/4 of the population in the cycling timeframes fell into either a transitory period of 0 to 1 month gap or a short, relatively short gap of 2 to 6 months. So when you get into the longer populations, it's only 1/4 of the population, which is still significant, you know, as we're looking at the continuity of coverage and such. But we do generally have very short gap lengths. So let's look for just a minute into the reasons that people left Medicaid or had a gap in coverage. And it's going to vary by population. For our low-income adults, most of the people leaving, or almost half, were over income. So again, that's getting to your economically sensitive populations. And as incomes go up, you lose Medicaid coverage. Another 1/4 of those people lost eligibility due to incomplete documentation. As they were reapplying or recertifying on an annual basis or such, they failed to complete the application, or they didn't turn in documentation that was required in order to move forward. When you look at the low-income kids, however, that proportion flips. So 37% lost eligibility due to incomplete documentation, and only about a quarter lost eligibility because they were over income. Their families were over income, which was really fascinating there. But again, with your children, they're going to be relying on parents, caretakers to complete that documentation. For our pregnant adults, 41% of leavers lost eligibility because they were over income. And that's to be expected, looking at that cliff that Sarah had so beautifully illustrated. The other 28% lost eligibility because they didn't meet other program requirements. And I'm guessing that the major one there is being pregnant. When you're looking at our older adults, unsurprisingly, most of the leavers were attributed to death. Then you also have incomplete documentation to try to get that annual review up and running. So for adults with disabilities, and this excludes the buy-in population where somebody with a disability and a working adult with a disability can buy into the Medicaid program, they're a completely different story. But for most of our adults with disabilities, the reasons for leaving are fairly evenly split between death, moving out of state, or having an incomplete documentation. So 3/4 of the leavers are going to fall into one of those categories. With our buy-in population, they primarily lose eligibility for not paying the premium that's required. So as we moved into the public health emergency, it was great to be able to see, to have that baseline. So we knew what our population looked like before we got here. Our caseload in Colorado Medicaid has grown over 1/4 from 1.24 million up to 1.57 million in the last year and a half. The growth has been slowing substantially over the past few months. So we see our spike here early in the public health emergency, and it's steadily gone down. This lower line here are the number of people leaving Medicaid over that same time span. Our growth was concentrated in our MAGI low-income population. We have, right here in our dark blue line, this is our MAGI adults. So those are our adults without dependent children. And that has grown at our fastest rate, followed only by our MAGI children, whose growth has been leveling off. Down here, we see our CHIP population, and that population has been dropping over the public health emergency timeframe, as we would expect, because there is a maintenance of effort requirement from CMS that says, hey, if you get on Medicaid, you aren't disenrolled until after the public health emergency. So instead of going back and forth between Medicaid and CHIP, the CHIP kids are transitioning onto Medicaid and staying there. We're seeing very modest or flat growth in our non-MAGI populations. So, you know, our foster care is almost flat. A little bit of growth in some of the populations. What we do see is the growth right here in our MAGI, non-MAGI buy-in working adult population. So what we're seeing are the people who may have cycled off in a normal time frame due to not paying premiums, who are maintaining coverage. These are our estimates. Because of that maintenance of eligibility requirement, once people come onto the program, they're staying throughout the duration. So over the past 6 months, anybody who has been eligible, we're retaining almost 95% of the population. And that steps down to 86% over 12 months and 75% if we're looking over the full public health emergency timeframe, because of course people have come on at different time periods. So there are 2 exceptions to the maintenance of effort, and that is if a person moves out of state, which is this aqua color right here, or if the person dies, of course, then you're disenrolled from Medicaid. So over the past year or so, we're seeing these 2 groups make up the largest percent. So what are those other bars doing in there? Those are administrative blips. In our automated system, there are certain triggers that will disenroll a person from Medicaid. So for all of these groups being not eligible, not verified, we couldn't find them. Those are little blips in eligibility where they drop off at the end of the eligibility month, but immediately gain eligibility the next day as our CBMS system goes back and corrects to re-enroll the people. So after the public health emergency, what we've been really excited about here in Colorado is that over the past year or so, we've been working to build a churn monitoring dashboard. And that will be used going forward in perpetuity, but will be particularly useful as we're watching people drop off after people are no longer locked into Medicaid. This particular dashboard is not public because it contains both full PHI and the capacity to drill down to aggregated numbers that don't meet our safe harbor limitations. But I want to show you some of the graphs. Some of the graphs that you have seen in this last part were screenshots taken out of that dashboard. But we will also be able to track our populations by new, leaver, returner, and stayer status. So as we see our population fluctuate, we're going to be able to see variations, seeing where we're dropping off and where people are coming on. We expect that the populations that drop off will be those that are growing or that have grown most substantially over the public health crisis. So our Magi adults, we would guess our Magi children. Earlier today, I was in a meeting with some of our budget forecasters, and they are anticipating that approximately about 30,000 of our Magi children will transition back onto CHIP after the maintenance of effort expires. And the condition limited populations we expect to drop a little bit. We will be able to keep track of our population that's being disenrolled as we're going through, and we'll expect to see this pink over income really shoot up and modulate. So once we get past our initial area, it will come down, but we're able to drill in by age group, by county, by whether they're emergency services only or not, by the disenrollment reason, so we'll be able to check and see, okay, what's going on with these other populations. We also, with our returners, since we're not looking at a set time frame, we're not calling them cyclers here, but we will be able to track the number of months, the percentage of the population by the number of months they have had a gap. So we'll be able to see if they were 1 month out, 2 months out, etc., by when they came back, and also why the people had left. So for instance, you look down a column here, for people who returned after 13 to 18 months, most of them had originally lost eligibility because they were over income. After 1 month, we'll be able to check and see, oh, was it because they had incomplete documentation and such? And finally, we will have some maps to track who's turning on and who's turning off. We are investigating ways to try to make some of this information public and easily available. That will be an effort that we're focusing on over the next few months. So we'll turn it back over to our civic folks and move on with our questions.
Thank you so much. Beth, great presentation. I appreciate everything that you shared. Thank you so much. Great work. And we do have a couple of questions, but I just want to, as we're taking the Q&A time, I just want to make sure that everybody has an opportunity to put their questions into the chat box. We would love to hear from you. Let me pull up, did I go away from my screen share, appropriate screen share, here we go. So for the first question, I think this is aimed at you, Sarah, from your investigation of the 138% cutoff for the postpartum continuous coverage. The question was, the folks who don't get that coverage due to the immigration status, and the question was that you wonder how much that group affected your results of your study. Were you able to parse out those folks at all?
Yeah, this is such a good question. I'm glad someone asked this, and it's something we thought about a lot. And we tried to get at this like 3 different ways. So we reran our analysis excluding people who had emergency Medicaid, because often this is provided for, for an acute event, such as the birth of a child for someone who might not be eligible due to citizenship. And so we excluded that group and reran it. We also took a much broader approach. We reran the analysis excluding anyone who wasn't born in the US. And so we were sort of trying to get at this without having direct citizenship information about individuals, which is not included in any of the data sets that I used. So doing that did not change the result at all. Really didn't make a difference. And I think it's just because these coverage effects are so strong that even excluding a portion of the population, as you're referencing, doesn't actually change the results.
That's great. And it looks like the same person, Bethany, thank you for asking questions, also is wondering about the churn rate for children. With continuous eligibility, you would think that kids would be unlikely to churn, but is Medicaid, HCPF looking at rates of X part renewal for that group by county to see whether that group could be reduced?
Actually, that's one of the reasons that was one of the things that we're hoping to really capitalize on with this new dashboard, is keeping track of what's going on with our children. There is 1 year of continuous eligibility, and after that year, due to CMS rules, we have to do a review, an eligibility review. And then, if the family is found to be eligible again, then they have another year of continuous eligibility. That's really where I was very concerned with our original analysis, where we're seeing the highest percentage of kids leaving because of incomplete documentation or because of an incomplete reapplication. I know that our eligibility team has been working hard to update the PCAP and the online website to make the reapplication process, the re-verification process easier, streamline it, to take out the administrative burden on our members' side, to really ease that. But that is still one of the big drawbacks, is that it requires your parent caretaker involvement to make sure that that documentation is completed to increase the continuity of coverage.
I just want to comment on that. I think it's such an important point that even in the presence of a 12-month continuous eligibility policy, you can still see churn because of this other source of churn, this administrative issue. I think it really points to sort of different policy solutions.
Right. And one other thing to know, in the 24-month study, when we were looking at people leaving, where the kids left, if they then joined or were transitioned to CHIP, they were still counted among that leaver population and cycler for that particular study. With our new dashboard, they're not, although we do have a subset of the dashboard that is looking at the migration between the CHIP and Medicaid coverage, because if somebody qualifies for Medicaid, they must be put on Medicaid, and if they're qualifying for CHIP, there's a much higher federal match rate, and so we move people to CHIP so we can then cover more people. And in normal times, there is a population of around 2,000 to 3,000 kids moving from Medicaid to CHIP and CHIP to Medicaid in any given month. So you do see a lot of transition there.
We have another question from Stephanie Brooks. Since there are health benefits associated with continuous coverage, would there be or are there plans to look at the health outcomes and maybe decreased cost per enrollee of the folks who had continuous enrollment during the public health emergency.
So do we know to whom that's?
It doesn't say to whom, so either one of you can take it.
Go ahead, Beth.
I don't have a very good answer to that. Could you repeat the question again?
Sure. Since there are health benefits associated with continuous coverage, would there be, or are there plans to look at health outcomes and maybe decrease cost per enrollee of the people who had continuous enrollment through the public health emergency?
Actually, there are plans for that, not specifically in that terminology. But one of the things that we've done with this dashboard that we've developed is we're migrating the underlying information for the dashboard out of CBMS and bringing it into our Colorado Medicaid's data warehouse, the BIDM. And so one of the things that we are looking at doing over the next several months, as I said, we're going to be evaluating it, is we are looking at merging that data in with what we called our executive level dashboard, which tracks utilization and expenditures and such. And so once we get that data paired together, we'll be able to track utilization and expenditure patterns and trends by these different groups, by the length of time they've been a stayer and that sort of thing. And yes, that was a very, that's one of our higher priorities, to get those data married and able to use for investigation.
That's really exciting, Beth. I'll just add that, well, two things. So there is research that shows that the longer Medicaid enrollee stays in the program, the lower their per monthly costs are. So there is some evidence to suggest that longer durations of enrollment are typically associated with lower costs for the non-elderly, non-disabled population. I think it's tricky to do much around costs and utilization during the PHE because it was such a unique period of time in terms of healthcare costs and utilization patterns. So us in the research community, we're saying, there's so many things you could look at, so many policy changes that happened during the pandemic, but it was just such an anomaly in so many ways that it's very hard to extrapolate sort of generally about typical trends.
And I think we have time for one more question that came in regarding, are you able to pull out churn information on people categorized as homeless and without a residential address?
Not reliably. We have dubious information in our system. So to the extent that somebody has reported on their application that they are homeless or in transitory circumstances, we can look at that, but we know that the data aren't kept up to date. So it might be surprising, but the first thing that people do when they have a change of circumstances is not necessarily contacting our bureaucracy to let us know. And so while we can do some analysis, it will always include the caveat of, we know that this isn't truly accurate. And I'm so sorry.
Yeah, it's a tricky one for sure. Well, thank you guys so much for your wonderful presentations. We've enjoyed hearing from both of you and look forward to more information, I'm sure, in the upcoming years as you guys continue your work. And I want to thank our presenters again and everyone who joined us. And I hope everyone has a great day. Thanks again. Take care.